It was Wednesday. A call came from the casualty stating the patient is acute kidney injury, urea is 200, creatinine is 10. The medicine resident on the another side, in the casualty, they want to give the dialysis because uremia is there in acute kidney injury. So the topic for discussion today is acute kidney injury and hemodialysis indication. See, in many places, even in coaching center or the some social media platforms, they are coming up with mnemonics A, E, I, O, U, and some other mnemonics that might be very helpful for multiple choice question, not at the ground level. So, if we have to discuss acute kidney injury, leave out the dialysis first. As a medicine resident, you should know why the patient landed in acute kidney injury. It could be pre-renal, renal, or post-renal. So this is the common etiology of acute kidney injury. Let us start with the indications. If I have to grossly say, in acute kidney injury also, hyperkalemia, similar to CKD. Indications of dialysis in CKD. I will give the link for that video in the description. If I have to tell in short, hyperkalemia, a high potassium with ECG changes. Metabolic acidosis, pH less than 7.1 or bicarbonate less than 5 is an absolute indication. Less than 10, a relative indication. Severe volume overload and any uremic manifestation per se. A high urea more than 180, creatinine more than 6 to 8. Any uremic manifestation starting from head to foot, encephalopathy, pericarditis, coagulopathy, gastritis, whatever uremic manifestation for that matter. But in acute kidney injury, the catch comes. Apart from this, anuria is an important indication. Let me discuss this in bit detail. Let us take a acute kidney injury which is due to volume loss. The patient lost a good amount of volume because of which the patient went into acute kidney injury. So the patient in casualty, if the urea, let us say value is 200, let us say creatinine is 10, if there is no hyperkalemia, no acidosis, no volume overload, this patient with the fluid is going to improve. Because we know the etiology from the history, we know there is a chances of recovery. So start the fluid, look for the hemodynamic stability of the patient and wait for the subsequent KFT report. Don't jump as per the mnemonic. Mnemonic is for the multiple choice or UG level understanding. As a resident who is working in nephro division or a nephrologist, this is the case you might be handling day in and out. This obviously you will come to know. First of all, assess the case. Why there is acute kidney injury? Why it is? You can't take a particular lab value and decide on the dialysis. Look what is the severity, what is the duration over a period of time, how many days the patient went into AKI, over a period of hours, days, the patient went into AKI, whether it is recoverable or not. Okay, you have to look as a whole. Many times in the post-operative period, let us take an example, a patient underwent any kind of surgery, post-operative period, urine output is nil for the past 12 hours. Let us take this as example number 2. Here urea's, let us take it as 85, creat as 1.9. But patient is in totally anuric state for the last 12 hours or 18 hours or 24 hours for that matter, despite giving the IV fluid or input to the patient. No output. Because usually the blood test was done at the morning, probably it might be repeated in the evening. The blood report is saying urea 80, creatinine 1.9, potassium is normal, bicarbonate is normal. Since anuria is there, patient started developing tachycardia. Here, if you take the absolute values, indication of dialysis is not there. But what we have to act as a nephrologist, or we have to take the decision is, the patient is having anuria, the subsequent report is going to worsen. We can't wait for the patient to worsen, then take the decision of replacement therapy, that is dialysis, or any renal replacement therapy for that matter. So if anuria, if no response to diuretic, yes, dialysis have to be taken at a lower urea creatinine value. Even urea 85, creatinine is 1.9, anuria in acute kidney injury, you might have to take the patient for dialysis on condition that you came to the probable diagnosis of acute kidney injury. Okay, these are interlinked concept. Don't expect a absolute answer. So this probably a amateur medicine resident or resident who is starting the posting, uh, you should understand. Try to understand the case as a whole. Try to understand the case as a whole. Why the incident happened? What is the chances of recovery? If sometimes you might not get any clue. So, Resmito, I am not getting any clue. What to do? See, there are age-specific most common things. For example, a volume loss indicates pre-renal AKI. Old age, most likely post-renal AKI. If ultrasound is there, history itself will clearly tell. A middle-aged female, chronic history could be any autoimmune disease. Glomerulonephritis is possible. Immediately after any IM injection, acute interstitial nephritis is possible. After sepsis, acute tubular necrosis is possible. Possible etiology and whether the patient is going to recover in the subsequent hours, days that you have to predict. If you think the recoverability is not there, the criteria can be lightened up so that at a lower value you have to take for dialysis. And one more thing with respect to hyperkalemia. In the clinical scenario, patient might have taken any drugs like telmisartan, enalapril, any RAS inhibitor. What is RAS? Renin, angiotensin, aldosterone system inhibitor causes hyperkalemia. Patient comes in casualty, potassium might be 5.9. Okay, AEIOU, that mnemonic I was telling, where one of the resident was asking, sir, electrolyte is high, let us take for dialysis. Patient have taken a drug which is a precipitating factor, it will resolve. So don't jump for dialysis because it is a invasive procedure, have its own side effects, own demerits. So don't jump into it, just try to catch the etiology why there is a hyperkalemia. Another example, let us put the discussion bit more clear. A patient who is 60-year-old coming to the casualty with complete heart block, secondary to hyperkalemia, treatment was given, the patient improved, that pacemaker has been removed which was put for complete heart block. But now the patient is having anuria for 12 hours only. Let us take for 12 hours. Creatinine, let us take it as 2.5. Urea, let us take as 120. Potassium, 5.5. At this particular point of time, yes, hyperkalemia is on the lower side. Urea creatinine is not so high. Only anuria is there. This time, considering the overall clinical scenario, what is the overall scenario? Patient went into heart block, TPI was recovering. Now we can't take the risk of not giving renal replacement therapy. You have to be preemptive enough to take the decision this patient is at risk. Dialysis have to be given. Okay. So assessment in CKD is different. In AKI, you have to assess in terms of probable recoverability, probable deterioration. Then fifth example, in ICU, intensive care unit, there are patients who are admitted with MODS, multi-organ dysfunction syndrome, respiratory failure on ventilator, patient is in shock. Any sepsis, for example, let us take pneumonia, kidney is also involved, urea creat value is not so high, potassium is normal, but gradually the urea creat trend is going towards higher side. What is higher side? From urea 60, it became 90. Then the subsequent 12 hours, it became 140. Creat also jumping from 3, jumping to 4, jumping to 5. Patient is on ventilator. Acidosis is not there. Urine output is there somewhat. The patient is not into anuria. So now what to do? Again, if you take the overall profile of the patient is in deteriorating phase. Already respiratory failure is there. Patient is in sepsis. Patient kidneys are deteriorating gradually. So you have to take the patient preemptively for dialysis. You can't wait for the criteria to come. Let me wait for hyperkalemia to come. No, because if hyperkalemia comes, patient might go into heart block. So we have to take the scenario as a whole. The risk patient might deteriorate in the subsequent hours. Yes, you have to take for dialysis. For that, etiology is very important. You have to, in the mind, you have to make the differential line, what it could be. So we can't go to absolute situation at 4 p.m. Okay, I will see for acidosis, hyperkalemia, urea value, I will see, I will decide yes, no. It can't happen. We have to give some time, assess the case, why there is AKI, then make the possible chances of recovery, then decide the need for dialysis. So this is the another example. And the subtle difference I told, in CKD probably it might be clear, whereas in AKI there is a high chances of recovery. That is why it is called acute kidney injury, because once we put the patient on dialysis, that patient ultrafiltrate is not moderated accordingly. Patient might be keep on going into the induced AKI state. Patient might not recover. So better to avoid dialysis in acute kidney injury, and also you have to preemptive enough to start the dialysis to save the person's life. So that decision you will start understanding as you start seeing the particular clinical scenario, where it started, currently where it is, what is the further plan. Always the goal is to stabilize the hemodynamic status, then bring the patient out of ICU, ward, then recoverability. I hope this is a bit complicated concept. I tried to put it as slowly as possible. And again, this is for MD medicine residents. Others might find it odd or difficult to understand. Okay, this is for MD medicine resident. And especially my request for the first year people, don't go by the mnemonic. There are so many mnemonic, AE, IOU, and a few people are coming with a pink bridge under which a bus passes. Every word ka first letter they are taking and making some mnemonic. It is not going to work. And once you became second year, you also tell your juniors to see the patient as a whole. Always look for the etiology, because once you look, the indication became wide open whether to give or not give. Pre-renal, very good recovery is there. You give the fluid, patient will improve, because we are having the reports of patient who came with urea 340, and the creatinine it was around 18 plus. Potassium was normal, as well. We just gave fluid, patient improved. Dialysis was not given. So this is another example. As you climb up your career, you will see more of these cases and you will be good enough to assess it. I hope this video is helpful, because so many examples I have given, and this video is for you, Divya, because you asked questions regarding this. Bye bye. We will see in the next video. Okay, summary I missed. If I have to tell the summary, in acute kidney injury and CKD, in acute kidney injury, anuria is an important factor. Before selecting the indication, see why the patient is in AKI, whether it is recoverable or not. Post-renal also very good recovery. If we take the indication, hyperkalemia, acidosis, volume overload, any uremia, anuria, which is different in AKI. Whereas in CKD, hyperphosphatemia, malnutrition forms then indication. In AKI, it won't form. So it is all regarding this subject of indication of dialysis in AKI. Yeah, in detail discussion. Bye bye.